Welcome, everybody. Thank you for joining on your Tuesday night, especially if you're in a heat wave like a lot of us in the mid West and the East Coast. And as always, the South are in, but it's really hot. So thank you for being here tonight. Um, Tonight will be about affirming care, LGBTQ plus health equity, and sexual and reproductive health services. And it will be facilitated by Tori Sparks, who will talk a little bit about themselves shortly. So a little bit about Repro TLC. We're a reproductive and sexual health organization rooted in training, liberation, and community. We provide clinical training, education, and support to expand access on full spectrum of comprehensive sexual health. Check out our website. It's linked in the messages to learn more about our program staff and how we're building a future rooted in justice and care. And I'll also just do a quick poll to see how many of you all have done a workshop with us before. So I'll just quickly launch it and it should be on your screen. I'll give it like 40 seconds. And you can just go ahead and click how many workshops you've had with us. Perfect. I'll give it like 20 more seconds. Awesome. So we have somebody here for their first time. Welcome. Two people here for their first time. We've had people who've done 2 to 4 workshops, and then people who've done 4 to 10 workshops. So if this is your first time, welcome. If this is your second, third, fourth, fifth, sixth time, we're so happy to have you back and for future workshops as well. So thank you. In our land acknowledgement. So we want to acknowledge that it is our collective responsibility to call out the genocide, forced assimilation, forced sterilization without consent, stolen land, family separation, and forced removal of indigenous people on this land. It is not enough to just call it out. It's also important to use the resources linked in the chat box to look at the Harvard Bias Test, native land tax, and the native land that you're on. Additionally, also donate your money and contribute to mutual aid. This is our workshop survey, so I know we just got started. However, if you have any needs that you need to hop off on, or caregiving needs or things like that, feel free to just go ahead and have this workshop linked. So that way, no matter how far you get through, you can still go ahead and give us some great feedback, and an option to win a $25 e-gift card, as well as receive like completion of training certificate for this workshop as well. So we'll be dropping this a few times throughout the chat, because we know people, may have to hop off. And I will go ahead and turn it over to our amazing facilitator and go ahead and spotlight them.
All right. Hello, everyone. Hoping that you can see me and hear me okay. If there's any issues with that, definitely let folks know in the chat and we'll troubleshoot. I'm really excited to be here with you all tonight, especially during Pride Month, and really excited to just dive in and give you a bunch of practical knowledge in addition to hopefully some really interesting things to think about. I like to start trainings with this quote by Ocean Vuong to ground us in this space of abundance and this space of a strengths-based perspective. So being queer saved my life. Often we see queerness as deprivation. When I look at my life, I saw that queerness demanded an alternative innovation from me. I had to make alternative routes. It made me curious. It made me ask, is this enough for me? I believe that being queer is a gift, and just one of the things I'm most grateful for in my life. And so while we are going to talk about things like health disparities, and we are going to talk about the ways that like being queer can be really difficult, I want to ground us in this place of joy and abundance and gratitude for everything that queerness and transness gives folks. And hopefully we can sort of remain in that space as we move through our content tonight. So we're going to do some introduction, some like housekeeping stuff, a little bit of reflection work. And then we're really going to dive in and do a little bit on gender and gender affirming care. What do we mean when we say gender affirming care? I'm going to be using that term a lot tonight. Want to make sure that we're all on the same page. And then we're really going to get into understanding where we're at right now. What is the landscape for LGBTQ plus folks, especially when it comes to reproductive and sexual health services? And where does repro justice and LGBTQ plus justice sort of intersect, or really like that Venn diagram is kind of a circle, right? And then we're going to do two sets of best practices. So there's going to be one that's kind of broad. I know there's folks who are here who are like very specifically clinic folks, and there are folks from a lot of different levels of organizations doing a lot of different work. So we're going to start with broad. We're going to do a little bit of like what this looks like sort of across org wide or clinic wide. And then we're going to do a little bit more clinic specific for clinical folks. And we're really gonna dive deep on what it looks like for care to be affirming and inclusive across the board. We're not actually going to do any case studies today because I got way too in depth with the best practices, but I am going to leave you with action steps. We'll make time for questions throughout and at the end, and then I have a great resource doc for you as well. So healthcare professionals, advocates, educators, community members, all of you who are here, I know who are committed to equity and care. We're going to advance the way that gender affirming care and trauma informed care overlap, and expand your knowledge and skills, hopefully in really concrete ways that you can take away with you today. We're going to look at the landscape and why people who work in repro should care about gender affirming care. I'm sure you all do, you're here, but really why those things intertwine, and how. And then we're going to really just dive into those best practices, those challenges and opportunities. I'm going to ask you all to do quite a bit of reflection work around your own areas of bias. I would say the misinformation and disinformation is huge because there's just so much of it right now. And make some commitments to change, and hopefully, add to our broad understanding of the way that reproductive justice affects us all, in really unique intersectional ways. So really throughout all of this, I'd love to center a growth mindset, and have us think about not necessarily like, oh, I've done all these things wrong, right? But just like, where is there opportunity for growth? Where is there opportunity for learning? Where are the opportunities instead of, where are the mistakes or the gaps? So a little bit about me. My name is Tori. I use they, them pronouns. I'm a limited license social worker. Right now, my main work is as a therapist specializing in working with LGBTQ plus people, adolescents, and really at that intersection of oppression and mental health. You'll see up in the corner here, all the queer sex ed you never got in school, is the curriculum that I developed that you can learn more about on my website. I've also been doing work as a gynecological teaching assistant for a couple years. So teaching pelvic and chest exams to med students and other folks who are training to be clinicians, teaching that to, in the most trauma informed and inclusive way. I'll be drawing a lot from that experience tonight. Sex educator, facilitator, sex education and social justice consultant and trainer. Things I'm really enthusiastic about, things I love: queer spaces, sex education, healing, adolescent development, gender magic, therapy, fat liberation, creating the world we want to live in, nature, animals, radical empathy, and water. Those are just some of my favorite things I wanted to share with you. And you can see on the map where I am. I'm just right outside of Traverse City, Michigan, which occupies the ancestral and contemporary lands of the Anishinaabe Three Fires Confederacy, specifically the Ottawa, Chippewa, and Potawatomi peoples. And I really appreciate that Repro TLC gave us such a fantastic land acknowledgement to begin with today. So I just want to encourage all of us to listen to learn this evening and really take the chance to reflect on our work and how we do it as a gift, as a something that we really can honor and be grateful for, and then allow ourselves to grow so we're not just freezing ourselves in a period of time. And people are coming to this space tonight, I'm sure, with many different levels of knowledge. And so we can be patient with each other, with other folks in their learning journeys. Of course, be present, breathe, take care of yourself. I will stop and take deep breaths. I invite you to take them with me. Um, and expect and accept a lack of closure. We're not going to get to all things tonight, but hopefully we'll create some really wonderful seeds or starting points. Expect and speak to your discomfort and joy as we move through the material. Um, of course, we want to respect confidentiality and take the learning and leave the stories. So much of what we're doing is breaking down binaries, and either or is a binary that a lot of our brains work in, because our society is built in a lot of binary ways. So I encourage you to work on the both and thinking. It's lifelong work for me, at least. Um, and then speak from your own experience, and be an expert in your own lived experience, and not necessarily that of others. So if we feel good about these, we'll go ahead and dive into content. I am going to be moving pretty quickly tonight, and it's really just because I prepared like a ton of content for you, and I really want to make sure we get to it. At any point, if you want to pause or ask a question, or just need me to say something multiple times for it to sink in, anything like that, please let me know. So I'd love to hear in the chat just for folks to take a moment, to think about hopes and fears when it comes to this training and this topic. And if you want to just think about them and not share them, that's okay too. I think it's important that we begin with reflection when we're doing learning of where we're coming from and where we want to go, and maybe what's getting in our way or stopping us, or just coming up for us as we do that work. Um, So I'm going to do my breathing, and I'm going to invite you, if you would like, feel free to share um, hopes and fears. And I'm also happy to model that for y'all and share that. um, I hope that you all take away really concrete steps that you can implement like tomorrow, and maybe years from now, both. But I think the political climate around where the LGBTQ plus community is right now, um, is a fear for me, and it's a fear in the way that it may give pause or get in the way of the growth and learning we want to do. It looks like there's a raised hand. Please feel free to share.
We have some people in the chat saying hope that they can learn things that can help their LGBTQ plus patients, and another one saying they are hoping to learn new information or resources to share with clients.
Perfect. Wonderful. Um, I am hopeful that I can provide those things for you. Um, no, I don't believe we can hear you. There was someone who raised a hand, but I couldn't hear anything come through. Wonderful.
Um, Awesome. We have people commenting. A community midwife of 26 years. That's amazing. Thank you. And reproductive and perinatal social worker. Thank you. I'm excited that we have you here today. And then we have somebody saying become more informed on how to treat LGBTQ plus patients with inclusive language and appropriate resources. Amazing. Thank you all.
All right. Now give us just a moment more. Looks like we're gonna have a couple more things coming in here in the chat. So far, I don't have any fears coming up for me that I'm not gonna be able to provide those things for you. So that's a good thing. All right. I'm gonna give us just one more minute for folks to share, and then we'll go ahead and keep moving and grooving.
We have our executive director here. They are a full spectrum birth worker, lactation consultant, and nurse. And they hope that we can all find small ways to have an impact and fear the overwhelm of this moment that may make us feel powerless. Thank you for sharing. That was great.
I share those hopes and fears with you. And my hope is to ground us in a little bit of just an understanding of that fear and why it's happening, so that, it feels a little less overwhelming if we understand it. Um, there's a lot of it that's hard to understand, but we're going to draw some parallels, and hopefully that'll help a little bit. Intersection of LGBTQ plus communities and abortion access. We're going to go there. Amazing. I'm gonna keep moving and grooving here, but I invite y'all to continue to comment in the chat as we go, especially as questions come up, or just reflections. I want us to stay very in touch with our feelings as we do this work, because I think it's a product of uh, colonization and white supremacy that we're not supposed to have feelings as we do our work. I don't operate that way. So please feel free to bring your feelings, as we move through this. I know I will bring mine. Um, the first place I want to start is a little bit of my thoughts and feelings on terminology. I do a lot of these trainings, and I often get a lot of people who are really curious about the right words to use. And I want to encourage us to um, move away from that a little bit. It's wonderful to use the right words, and we are going to talk quite a bit about using the right words. And language is always changing. And so this need to like have like term and definition, I must have glossary, um, is important. And also, I think can be a little overwhelming for folks as a place to start. And I want to encourage us to practice the communication of sharing, like, I have never heard that before, and I would love to hear what that means for you. Or, can you tell me more about that experience? And of course, allowing folks to say, like, no, go learn it yourself, and that's fine too, right? But I want us to think about how new words are not necessarily new concepts. And so another thing I hear in trainings a lot, is like, I just can't keep up, there's like so much that's new, and that's totally valid. It can also be a little hard to hear because I think we're all just trying to find the right ways to describe the way that we experience the world as a person with a body, and living in the context that we do that gender our bodies, um, and do a lot of other things conceptually around the fact that we're just people with bodies. So we're going to do the words, we're going to do the terminology, we're going to do a lot on inclusive language. I also want us to think about how like mastery of all the words and definitions, um, is not all there is, right? And this, of course, is moving us from this space of cultural humility and accountability, so that we are continuously engaging in self-reflection and self-critique, and we are taking into account the fluidity and subjectivity of culture, as not something that we can, 100% know and understand, and even, like reject that urge a little bit, and really instead emphasize active engagement in a lifelong process of humility, a recognition of power imbalances, and just being really accountable, accountability to institutional barriers, moving from this focus of, a mastery and understanding, quote unquote, others. So, again, just like some more places I want to ground us in today. Okay. Um, so I'm not going to do an LGBTQ plus 101 this evening, because I have a lot of things to share, and I don't know if that's really where we're starting tonight. That said, if you're like, I think I need some more help understanding some of the basics, happy to provide those resources for you. We are also going to focus a little bit more on trans and folks under the trans umbrella identities tonight, looking at trans and intersex and non-binary folks. Really, essentially because we are the most under attack right now. And at the same time, we'll integrate, a sexual orientation lens as well tonight. But I want to start with talking about transition and gender affirming care a little bit, because we are going to talk quite a bit about gender affirming care tonight. Um, so we can look at transition as social transition and medical transition, and really thinking about the way that a person might take steps to socially or physically feel more aligned with their gender identity. This is a really complicated process. It's not just like a one-to-one, but to simplify it here, we can think about the ways that folks might make changes in their social interactions and processes, in addition to making changes to their appearance or presentation or expression. So these are not necessarily the same thing, and one is not more valid or important than the other. Similarly, people are still very valid in their identities if they choose to do no transition at all. Everyone's experience of it is different, and not everyone even uses this term transition. But it is one of our key concepts as we look at gender affirming care. So anyways, I add here, a special note that not all trans people transition in any way the same way, both socially and physically, etc. I'm going to look a little bit at medical gender affirming care. To start here, that's going to be quite a bit of our focus tonight. So medical gender affirming care may include puberty blockers, which delay the onset of puberty. Which we're not going to dive too far into tonight, but if you all have questions, more than happy to answer them. Estrogen and testosterone gender affirming hormone therapy, top surgeries such as mastectomy or implants or reduction, potential removal of reproductive organs, for example, a hysterectomy or orchiectomy, cessation of menstruation through contraceptions, and then bottom surgery, vaginoplasty, phalloplasty, metoidioplasty. This is not an exhaustive list, but this is some of the things that we are thinking about and talking about when we talk about gender affirming care in the medical or physical sense. More broadly, when we look at the World Health Organization or a broader definition, we're looking at a range of interventions designed to support and affirm an individual's gender identity when it comes to the gender that they were assigned at birth. So as a therapist, I provide gender affirming care when I am working with somebody and helping them best understand their identity. As someone who works in a medical clinic, providing gender affirming care is making sure that the medical services that you're providing are the ones that the person is choosing, and that they have that level of autonomy. You see the threads to repro justice here. Great. And that's happening in a way that allows them to feel most affirmed in their gender identity, specifically when that gender identity conflicts, or not even conflicts, but just like doesn't align, doesn't match up with the gender that they were assigned at birth. So to go a little further here, again, we're going to be playing with these concepts quite a bit tonight. I want to make sure we have like a shared understanding of them. This resource comes from Planned Parenthood of Michigan, which I'm really proud to have worked there for many years, and they have great resources. Their gender affirming care program is very strong. And so to give us a sense again of what is gender affirming care, it's a whole range of things. We're going to look briefly at gender affirming hormone therapy. So here's what we might think about or see when we talk about testosterone based therapy. And I think that this is a really interesting and important resource because it provides information on reversibility as well as how long one might expect or think about an onset for that effect. And what that timeline might look like, knowing that it is very different for everybody because we all have different amounts of hormones in our bodies. This is a resource that you can find on the Planned Parenthood of Michigan website under their gender affirming care program. So similarly, when we look at estrogen-based therapy, we have a chart here that explains a lot of those changes. I will add that typically we're looking at a dual therapy here with an androgen suppressor as well as estrogen. As far as that androgen suppression, that's often it's spironolactone, but there are multiple ways that this care might be initiated, and I'll talk through what the standards of care look like and where you can find them if that's something that you would like to learn more about. I want to pause and breathe and also invite folks. We're just in like the very tip of the iceberg here, but I will definitely invite folks to ask questions at this time. And like I said, anytime I take a deep breath, I encourage you to do the same. It's only going to help your learning. All right, I'm going to keep moving with our content, but please questions anytime. I always want to frame a little bit also that like gender affirming care is something that most people access when we're talking about medical or behavioral emotional care, social changes that folks make to be more in line with how they feel about their gender. Um, and there's usually no question about whether it's legal or available or possible when cisgender people access it. So some of these things might look like, somebody feeling more embodied in their gender if their breasts are larger. If they're a cis woman, if and they want larger breasts, right? We don't keep people from accessing that as a society. Um, Similarly, things like shoe lifts. Somebody might feel more comfort in their body and their gender if they are taller, right? Typically, we're looking at cis men when we're looking at this as gender affirming care. So again, just like framing some of these things, giving us a little perspective. Hair removal, hair plugs or transplants, breast reconstruction after mastectomy is a fantastic example of how one might feel not at home in their body if they no longer have breasts and they would want them reconstructed. Um, 97% of the gender affirming surgeries that were done on youth, I believe in 2021, was for gynecomastia. Gynecomastia is a condition where people who are cis men, and often we're looking at cis boys, again in this context, have larger breast tissue, larger chest tissue, and have that removed so that they can feel more in line with their gender presentation. Super common. A really large amount of the gender affirming surgeries that are done for youth are done for gynecomastia. When folks experience a change to their reproductive organs due to cancer, specifically penile and testicular implants after testicular cancer, as a field, we have been prescribing puberty blockers for precocious puberty for a very long time. It is not a new treatment. Precocious puberty meaning early onset. And similarly, delayed puberty, right? If a young person reaches an age where they feel they should have started puberty already and their doctor agrees, hormone replacement therapy is initiated with no legislation, with no letters from a psychiatrist, et cetera, et cetera. Um, Hormone replacement therapy for low testosterone or menopause and Viagra. These are all examples of gender affirming care that we really don't even question. And I see there's something in the chat as well. Um, Yes, lactation support, such as induced or augmented lactation for postpartum cis women as a common gender affirming care. Absolutely. That somebody would feel more at home in their body and their gender as a mother to be able to lactate. And if they're getting support with that, that's a fantastic example. Thank you so much for sharing. Um, so, transition and specifically medical gender affirming care is a costly, lengthy, and basically difficult process in every way. When I use this term gatekeeping, I'm talking about, and when I say health professionals here, I also want to add and some of this happens legislatively or it happens through other like structural forms of gatekeeping that are hurdles in the path of affirmative care and require folks to really prove who we are and that we really want or really need access to medical affirming care. Um, these can be life-saving interventions. I'm going to talk a little bit more about the way that we talk about this as life-saving in a little bit, but that's actually, true that it's life-saving care. So there are folks who may refuse to take on trans patients or clients, or require unnecessary steps in order to access care, such as mandating a psychiatrist or endocrinologist assessment. This concept of watchful waiting, which is like just delaying care and kind of seeing what happens, seeing if something sticks. Folks do this with youth quite often, without that clear health-based reason. Not providing all the information or answers as to why particular decisions have been made. Um, Requiring trans people to adopt a binary identity or perform dysphoria in a certain way. Um, Having a, this often looks like having a really limited um, version of what a trans person's story is, often requiring that ever since I was little, I always knew, um, or the narrative of like being in the wrong body. They're not invalid narratives, but they're not everyone's narrative, and they shouldn't have to be to access care. Um, Invasive or unnecessary examinations or testing to access care. Rapid onset gender dysphoria is not a real thing, but it has become something that anti-trans folks talk about as like, out of nowhere, this child just started to have gender dysphoria. That's been disproven. This is not a phenomenon that is realistic or applicable. And what we're missing here is that often before someone comes out, and especially a young person, this is something they've been thinking about, in really pretty major ways. And if it seems rapidly onset, it is likely because they have been too scared to talk about it or show that before. And so, while a parent or caregiver may feel like it's coming out of nowhere, there are so many pieces of that person's journey, and specifically their own thought process, or even the way that they have been expressing themselves outside of the home, that are not rapidly onset. And then the overinflation of regret rates. Regret rates are incredibly low for gender affirming care, and they're actually quite high for a ton of other medical procedures that folks get without issue. Um, there are things like hip surgery and knee surgery that have like huge regret rates, as well as a bunch of other decisions that we allow folks or encourage folks to make, without barriers, without gatekeeping, that have quite high regret rates. And so the regret rate gatekeeping is, again, it's a part of a really targeted disinformation, when regret rates are incredibly low, for gender affirming care. So we're going to continue talking about misinformation and disinformation. Yes, and this is very similar. We're beginning to draw the parallels that we have regret rate inflation for abortion care. Exactly. So this idea that we can't trust people to make their own decisions about their bodies, it's all coming from the same place, right? That people can't be trusted to have their own inner processes around decision making. Regret rates for parenthood are quite high, but no one really talks about that, right? But they talk about, they talk about regret rates when it comes to abortion. And so this limited bodily autonomy through, these concepts of like, I know better than you, what you're going to regret later, we really only selectively apply to stigmatized decisions when it comes to bodily autonomy. So, I wrote us up a recipe for a moral panic. And I did this because moral panics are something that repro justice addresses quite well, in terms of like identifying where there's been a moral panic inflated around bodily autonomy, around decisions that folks make for themselves. And so again, I want us to sort of begin to draw these parallels, and again, not even parallels, the Venn diagram is a circle here when we look at LGBTQ plus care and rights and reproductive justice. So one of the things that moral panics do really well is focus on women and children. And this is a really paternalistic way of doing things, and also usually, unfortunately, very effective. And we can think of, I encourage y'all actually in the chat to brainstorm some moral panics that you have seen or studied that impact your work or just have impacted life. Or that you've learned about that sort of follow this recipe, because there's a lot of them. So, like we talked about, the overstatement and weaponizing of future regret, the blaming of an internet social contagion, and also over blaming and total misunderstanding of how trauma works, um, and weaponization of folks' trauma for a moral panic, undermining science and the medical field and vilifying providers. We see this, co-opting the like very legitimate distrust in medical professionals due to racism in service of limitations to bodily autonomy. So again, like really weaponizing and twisting where folks have a very legitimate distrust due to history. Um, Looking at the emphasizing of traditional family roles, and this includes eugenics and natalism and gender roles, spreading misinformation aimed to shock and dismay, and weaponizing religion and quote unquote God's design or God's plan to mobilize church communities. Um, some really, really good examples here in the chat of the way that quote unquote crack babies became a moral panic through really the really racist marginalization and vilification and stigmatization um, of mothers and birthing parents. And really overinflation, right? This idea someone else shared, the kids will be so confused, that's said about poly clients and families with multiple co-parents. Exactly. Yes. So this like we must be concerned about the kids. And there's a lot of things that kids likely find very confusing, gender roles being one of them. They're really hard to understand as a child. Um, and that never comes up, right? um, So some really good examples here in the chat of ways that we can sort of draw some really important parallels, draw some lines here, and see that, at the end, if we look at reproductive justice as a strategy, it's really effective at showing and telling us and helping us understand the way that so many of these things are really well connected. And I want to, just shout out here, the National Women's Law Center did a really great job of drawing anti-gender affirming care and anti-abortion strategies on sort of a one-to-one basis. So more of our recipe here, world's worst recipe. Capitalizing on economic instability and financial fears to misattribute blame for those economic issues to social issues. When we hear people talking about like, what about the eggs, the price of eggs, right? As like a redirect or a way that that blame for economic issues has been sort of moved to social issues. Reducing people to their reproductive capacity in so many of these issues, and really dehumanizing in that process. Amplifying rare stories of regret and cherry-picked anecdotes and fringe experts. There's probably 5 people who have just detransitioned, who transitioned as young people, who have entire careers with their speaking engagements. There's literally maybe 5 of them who are very outspoken, and it's a very small number of people, and they are very positively reinforced to be doing that work. Similarly, there's a couple medical professionals who have gone against the guidelines of their certifying bodies and medical boards, and those folks are held up as fringe experts. Promoting a misunderstanding of the nature of health disparities and trauma. I'm going to get into this a little further because these public health concepts that are really important, like health disparities and the way that trauma affects people's health decisions, gets really, really twisted and misunderstood in this process and weaponized. Um, and then looking also at, just trivializing and stigmatizing um, as a big part of this process. I have actually not yet read this new Judith Butler book, but Joe was kind enough to recommend it as a really great source for more information on the moral panic of gender, and so I'm excited to read that at some point and dive a little further in. I think about moral panics like constantly. Okay. I said that I would talk about health disparities, so I'm going to talk a little bit about health disparities. When we look at health disparities and a misunderstanding of them, we're usually looking at people misunderstanding correlation and causation. And so this is an example of how that misunderstanding may happen. A lot of us have had really hot and sunny summer weather. And when there's hot and sunny summer weather, get more sunburn, and ice cream stores sell more ice cream. Both of those are caused by the fact that it's hotter outside. If we were to put a graph of ice cream sold and sunburns treated, they would line up, but we would not assume that ice cream causes sunburn or that sunburn causes ice cream, right? So when we look at two things that change at the same rate, we cannot assume that one causes the other. This example is really pertinent and really important when we think about health disparities. So when we see a higher rate of, let's say, dating violence amongst LGBTQ plus folks, um, what we are what some folks who misunderstand correlation and causation, right, might say is that, well, that's because LGBTQ plus people are more violent or more cruel in their relationships, right? That is the same thing as saying ice cream causes sunburn, right? Because what we're missing there is the hot day, which is often it's minority stress. Um, Often it's the pressure that's put on relationships when they're marginalized and stigmatized and dangerous for folks, right? I could do this with tons of other health disparities, but often we really, folks, and when I say we, what I'm really talking about is this like moral panic piece of people who will say, well, look, right, the study, there's a correlation. This is how a lot of fat phobic medical things happen. This is how misunderstandings of health disparities in race happen. And this is also often what happens when folks are really misunderstanding and spreading disinformation and misinformation about the ways that systemic factors affect people's own health and their own lives in ways that are not, and I don't even want to use this word, but are not their fault, right? Um, I always want to make sure that we have a shared understanding of minority stress theory as we look at health disparities and health equity. This is an example of minority stress theory as it applies to LGBTQ plus folks from this Queer Mental Health Workbook. Minority stress theory is something that comes from the work of Black researchers understanding health disparities and weathering of Black women, and I want to make sure to attribute that um, that gratitude for that work where it belongs. But I do want to point to here that these experiences of, let's say, developmental and mental health difficulties, right, where we see much higher rates of depression and anxiety in LGBTQ plus people. This is part of this cycle of withdrawal from society and relationships and anger at the world, anger directed towards selves, internalized homophobia and transphobia, exhaustion and burnout. And then those mental health difficulties are seen as evidence for homophobic and transphobic agendas. And living in that heteronormative and cisgender normative world, excuse me, causes this minority stress, which causes the shame and marginalization, which causes the mental health difficulties, which causes the withdrawal and exhaustion. And it's a cycle, right? And so this is actually how we should be understanding health disparities when they concern marginalized populations. And I'm not going to throw too many statistics at you because I think that we all know them and hear them a lot. And if I'm wrong in that assumption, let me know and I will happily share some resources to learn more about these disparities. But it's important that we pick them apart and we understand why disparities happen and that we're not saying that or assuming that ice cream causes sunburn, right? So the tactics for these moral panics are a targeting of Medicaid and federal funding and tossing things to states' rights. We see this across many issues. An attempt to legally redefine informed consent. Again, with this really paternalistic idea that people don't know what they need and shouldn't have bodily autonomy. Threatening providers and forcing them to prioritize their own and their family's safety, just as being an abortion provider is can be very dangerous for people. Providing gender affirming care, especially for youth, can be very dangerous for people. And then people leave the field or don't offer that care because they care about the safety of themselves and their family, and they should not have to choose. Um, Expanding liability for medical malpractice. If you make people really afraid to be sued, then they're not going to provide the care. Imposing those gatekeeping and restrictions, always starting with the rights of minors. We see this across the board. And then this like really convoluted piece around parents' rights that we're going to dive into a little bit more. As a sex educator, no stranger to how parents' rights gets sort of manipulated in service of these moral panics. And we'll dive into that a little bit more when it comes to gender affirming care. And the recent Supreme Court decision. Doing my breathing. So the targets here, when it comes to moral panics around gender, is that we're looking at research and public health communications. It's really hard for people to get funding to research the needs of trans folks. Sports, bathrooms, healthcare, documentation, education, employment, art like drag, adoption, child welfare, foster care, incarceration, military, and lifelines quite literally. The National LGBTQ plus suicide hotline, it was just taken off of 988 and defunded there. So life, like literally lifelines, right? In addition to things like employment, sort of metaphorical lifelines. All right, so like 5 days ago, this Supreme Court ruling came down, and I was like, gotta talk about it. Again, for time, I'm gonna try not to talk about it at length, but I do want us to have a bit of an understanding of it because it is a big deal, and you likely heard about it. So the Supreme Court upheld a Tennessee ban on puberty blockers. The ban basically is that they what they did was that they ruled it wasn't discriminatory per the Equal Protection Clause, meaning that it doesn't require heightened scrutiny for the reason for discrimination. On puberty blockers and hormone therapy prescribed in ways that are quote unquote inconsistent with a child's sex. Again, puberty blockers are prescribed to cis kids with quote unquote precocious puberty without problem, right? Similarly, hormone therapy for delayed puberty. 24, and actually I think we're at 27 of these states have attempted these bans. So I'm drawing here from Chase Strangio and his work. He is the co-director of the ACLU LGBTQ plus and HIV rights project. He's the first trans person to ever argue a case in front of the Supreme Court. He argued this case. This is the person that you should be getting your guidance on anti-trans legislation from. Full stop. So again, drawing from his some of his guidance around how we can think about this is absolutely devastating, 100%. And the fight is not stopping, never has, never will. There are quite a few avenues for continued litigation. This is a narrower decision than it could have been. Bostock is a 2020 anti-discrimination case around Title VII, and this left Bostock intact, which is a good thing. because it means that more litigation over other forms of discrimination by the government remains open and possible. So I'm not a legal expert and I don't want to dive too deep into this, but I do want to give us a sense of what this looks like and what it means. Um, I said that I was going to talk a little bit about the framing of care as life-saving, and I'm going to do that now, just when it comes to talking about trans youth. So, is gender affirming care life-saving for trans youth? Yes. There's a lot of research that says that it is. There's a lot of research that says that it keeps them alive. As someone who works with trans youth, when they hear that something that saves their lives has been taken away, and that because of it, they're more likely to attempt or complete suicide, um, I want us to be really careful about the way that they internalize that messaging. And the way that that doesn't give them a sense of like, look, this does really suck, and you're going to make it to adulthood. Um, and giving a sense of, look, like, there's no denying that this is devastating. There's no denying that you need this care, but you can and will make it to 18. Right, and making sure that we're framing that. It's almost like when a toddler falls down and they look up at their parent to see how freaked out they should be, right? We absolutely should be freaked out, and the research is very clear that this is life-saving care. They also are looking at us to see whether this will actually end their lives. And so instilling that sense of resilience and hope in them, while also acknowledging how devastating this is, and also acknowledging that they deserve better and they deserve access to this care and they deserve to be fought for to get it however it looks. And that there are plenty of trans people who initiated their transition later in life, and when they turned 18, and they made it, and the kids can too, right? So there's just a lot of nuance here, and I hope I'm conveying it, because these things can be really hard to talk about, and we do have to frame them as life-saving because they are, right? But if you have trans youth in your life and they're a toddler who just fell down and they are looking at you to see whether how to get back up and how big of a deal it is. And if you scream and cry, they will scream and cry too. And so instilling that sense of resilience in ourselves and in our communities right now is really important when it comes to the little ones. And I really hope that makes sense, because I also want to underline how crucial and life-saving this care is. Um, oh, the other thing I was going to say here is that parental rights become really hypocritical here, because if it's a parent's right to decide their child's care, it's a parent's right to decide that their child needs access to gender affirming care. And it's like, okay, I thought we were all about parents' rights, right? But not here. Um, and again, we see this on attacks and abortion too. It's parents' rights until it's not, until a parent is okay with their child accessing care. Um, and I finally want to highlight here that these health disparities that we look at and the impact of this legislation and these moral panics and the targeted effects have the highest and most impactful impact. I'm losing the word I need here, but the most devastating impact, really, most deadly impact, is on transgender people, as we've talked about, but the intersections of transgender people of color, specifically Black and African American transgender people, and bisexual cis women, which can surprise some people, but bisexual cis women bear the brunt of quite a bit of the health disparities that we see. Again, often in comparison to lesbian women and gay men. Living at the intersections of transphobia and visible gender nonconformity, racism, sexism, biphobia, and misogyny, this is where we see the most alarming rates of violence and health disparities, and we need to center that. Specifically, when we look at the the issue of trans misogynoir, which is a very specific oppression of Black trans women and Black trans feminine people who are located at the intersection of anti-Blackness, transphobia, and misogyny. This is where intersectionality, I mean, it's crucial throughout, but it's really, really important that we center intersectionality, and that means that we're centering the most marginalized when we're looking at these targets and these moral panics and these the way that interpersonally even that people are impacted when it comes to violence. Okay, taking my deep breath, checking the time. We're rocking, we're rolling. We've got a lot more to cover. I've got a lot of really interesting skills to share with you. So I'm going to roll through these practice recommendations and encourage you to continue to breathe and also ask questions in the chat. Okay. So the first 10 practice recommendations, these are a little broad. These are broader on purpose because they can apply in a lot of different settings. And that's important because y'all work in a lot of different settings. So a welcoming environment. I always use this exercise of like the world's worst waiting room for services. And we could go through if we had all the time in the world, we could go through these one by one and talk about like why this should not be in your waiting room. I will point out a couple of things. This provider is standing above the patient and not eye to eye. And so the patient has to look up and the provider has to look down. I'm going to go back and forth between client and patient language here because I use client language in my practice as a mental health provider. Yeah, most everything else, I'll point out chairs that don't work for larger bodies. I'll point out as a person with chemical sensitivities, like get your air fresheners away from me. You're gonna give me a migraine. All these other things that, you know, there's a lot here, and this covers a lot of different intersections. I specifically hate this bathroom sign. This is like this picture of like this third person is a really odd half and half picture. I am not a fan of what's going on here. I will tell you that I'm also not a fan of like whatever, just wash your hands, or like aliens, you know, whoever. Let's just be clear and say all gender, because we don't want to reinforce any odd, stigmatizing, weird messaging that can come along with any of that. Right. Actually, our restroom signs, the best way to do this is to share pictorially, as well as in Braille and written letters, what is in the room. Right. There is stalls in this room. There are stalls and a urinal in this room. People can make the decision of the room that they want to use the restroom in based on the equipment in the room, and if that equipment is going to be the equipment they want to use to go to the restroom. It's super plain and simple. And so I really encourage that folks move towards this when it comes to restroom signs. Any single use restroom is all gender. Quite a few other things going on here that are making this waiting room and this office a more inclusive but also just accessible space. I also want to acknowledge that we don't always have control over the spaces we work in, and we don't always get to change things like the lighting, or, you know, I want to acknowledge there's a lot of realities here of like, if you're buying fidgets for your office, you're probably doing it out of your own pocket. I know I am. And there that, you know, I want to acknowledge the barriers here, but I also want to acknowledge that like if this is, you know, if we were just looking at the waiting room from hell, then this is a really idealized waiting room or office space that we want to be sort of striving towards. And if there are questions about why something is included here, please let me know and I'm happy to explain. I do trainings around fat liberation as well, and so you're going to see that sort of throughout here. All right, when we're talking about paperwork, I've got a couple different recommendations here to make things clear. I would always clarify that if you're asking for any legal name or legal sex information, that's because it has to match insurance or there's going to be issues. Um, and then just what name would you like us to use? And if you need the information asking about, someone's gender and their pronouns. Um, yeah, fat liberation. Fat liberation is not separate from any of the things we're talking about tonight. I'm glad to see that the appreciation for that in the chat. Um, Sharing your pronouns or having your own pronoun pin on your lanyard can be a great step here. We want to avoid honorifics. And then we also want to be clear if we need to ask for someone's information, that is not the information they prefer to share, why we are asking. Because it's likely for something administrative like insurance. But people may not realize that, and it's important to be very transparent about why we need the information that we need for all sorts of things, right? Um, it's policy, and I want to make sure that like you don't have insurance issues. Here's the context and reason why I need that information. A little more detailed here. And this would be looking again at more of a mental health setting or a community services setting, and that we're asking for language interpretation. None of these are multiple choice. Ideally, all of these things have a line next to them where the person can write it in, or they can have an advocate write it in for them, and that it's not multiple choice. Again, here insurance records list two sexes, so it is, but everything else is not multiple choice. It's fill it in, and then we offer support for folks who might need help with literacy to fill it in, so that no one has to check the box other, which is like literally othering, right? Consider parent/guardian 1, 2, 3, 4. We're accommodating different family configurations, and acknowledging the really wide range of ways that people raise their children, with different situations, and we're normalizing that, making space for that. Um, could your chart be under a different name? What's the name on your insurance? Um, I see this in paperwork often, questions that are noted as female only. Could you be pregnant, right? Or like male only. Have you had, XYZ? That's really not relevant if you're asking, like, is there a possibility of pregnancy, right? We don't need to clarify female only. That's unnecessarily non-inclusive. Um, and also, trans people often retain many natal and reproductive organs. So we want to make sure that none of our charts have like female only or male only sections. It's a really odd thing, and I see it a lot. I'm going to talk about pronouns. I'm going to breeze through this, but I also am going to be very clear that it's incredibly important. The Trans Allyship Workbook is one of my favorite resources by Davy Schlasco at Think Again Training. Highly recommend the book as well as Think Again Training. Most people are really, this is a quote from the book, that most people are really usually on autopilot, and autopilot doesn't work. And so, for many trans people, the wrong pronoun is one of the most painful things that you can call them. And that's because you're in effect announcing that person's gender. And most people feel pretty attached to their gender as a really core aspect of their identity. And so that is creating a situation where there's this implication of really not seeing someone as who they are. And that's something that we all deserve. The effects of misgendering can go all the way from annoyance and confusion to being targeted for violence or feeling unsafe, triggering some of that internalized oppression. I know that that's what happens for me when I'm misgendered. Um, Being outed, losing relationships, this huge range of things that it's really important to consider. Um, and that the research really backs this up, that this is like so important. So please like make an effort in whatever setting you're in. And also if you make a mistake, Like, just say sorry, correct yourself, and move on. There's nothing more awkward than having someone over apologize. I think I'm going to get to this later, but I'll mention it now. Just because you know how important it is doesn't mean that over apologizing is going to make anything better. It's really, really awkward to comfort somebody once they've misgendered you. So just a quick sorry and correction and move on. It was great. Um, let's see here. Yeah, just including again, we use the singular there all the time. It's actually really it already exists in your vocabulary. The neural pathways are fully there, they're formed. Um, using, some of this inclusive language around parents, siblings, children, partner. We don't need to attach a gender to a relationship. Um, and titles and honorifics are important. Many people see them as a sign of respect, but they also announce gender sometimes in ways that feel unnecessary. They open the door for misgendering. Um, if needed, just provide alternatives, or just ask, like what title somebody prefers to be called. Not to mention that they may very well be doctor, right? Um, Also, culturally, linguistically, we do this thing where we announce somebody's marital status, but only if they're a woman, right? Titles are super complicated. And if they're a part of how you feel respected, I honor that and I see that. But I also, just across the board, encourage folks to exercise a little bit of caution there. Um, Make it a habit to ask and respect people's pronouns and state your own, not only when you feel doubtful of someone's pronouns, make it the standard. Um, and some people might give you like a look, and some of that is just adjusting to that. Um, there are some settings where announcing or asking for a pronoun could be a safety issue. I honor and see that, and have been in that situation myself. And so obviously make those decisions the way, you need to, but just asking someone, like, are there ways that I can make you feel most respected in this setting? Right? Cool. You're not specifically asking like what title do you use or what whatever, but like how can I make sure that you feel most respected by me? Are there things that you would like me to know? Right? That can be wonderful if you're a service provider for somebody. Um, and if asking for pronouns specifically feels difficult, but just opening the door for folks to share whatever that information looks like. Um, so I'm going to briefly do a little bit of, I don't know, 102 on pronouns here. Um, Sometimes folks use multiple pronouns. So, for example, they, she, or he, they. You may see he, she, and they. It's always good to clarify, excuse me, with someone, and again, with the appropriateness of the relationship, excuse me, whether somebody wants you to use both interchangeably, or they're okay with either one, right? Um, I guess what I would say here is that people often will use whatever is most comfortable for them, and that often is going to be most in alignment with what they see when they look at someone. And so making that extra effort to be sure that like whatever pronoun someone is asking for gets actually used. I used she they for a very long time, and I got she almost all the time, and I was like, does anyone see the they? Right? So just making that effort to make, so I cannot speak for everyone, I cannot speak for everyone's relationship with their pronouns. That's my lived experience. And again, I ended up preferring they them at the end of the day anyways, but just wanted to add that sometimes folks have some questions about multiple pronouns. If you don't know someone's pronouns, it's okay to ask. It's okay to use they. We use they when we don't know someone's pronouns already, right? If I ask like, did your cousin call you? What did they say? I don't know the gender or pronouns of your cousin. I'm using they them because I don't know, and that's a very natural thing that we do in the English language. Someone shares that they use no pronouns or any pronouns. So when someone says they use no pronouns, likely they mean that they want to be referred to by their name. You can clarify that. If someone says they use any pronouns, again, um, honor that, clarify if you need to, and then, that may mean that they truly want multiple pronouns used. Um, if you're unsure about using pronouns in different situations, it's a great thing to ask, right? For example, maybe you're working with a minor patient or client. Um, is this a pronoun that you want me to use just here in my office, or is it okay if your parent or guardian hears this pronoun as well? Right. We're just making space for folks to really self-define safety in a world where pronouns have become a safety issue for a lot of folks due to, you know, not only our political climate, but also the potential to be outed. So here it is. If you're having trouble or you made a mistake, hold yourself accountable. Ask other people to hold yourself accountable. Practice if you feel nervous. Truly just talk to yourself about that person just to practice and make sure that, again, like those neural pathways are connecting. Apologize quickly, correct what you said, and move on. Um, this is an exercise. Some of this is from the Trans Allyship Workbook by Davy Schlasco. Again, highly recommend. Um, think of one trans person that you have difficulty using their pronouns and reflect on what your relationship is to this person and why it's important to get it right. Make explicit what is implicit there. Um, you can always try using different pronouns for your pet. I don't think they'll care if you need practice. Talk with other allies and then dig deep on why that's hitting a speed bump in your brain. For example, yeah, I really have trouble using she for that person. Again, do this on your own time, not in front of the person. I have trouble using she for that person because she has a beard and my brain goes beard and goes right to he, right? Make that explicit for yourself in your own reflection so that you can actually break those like create the connections you want to connect and break down some of those barriers and speed bumps and just become cognizant of them because they might be outside of your consciousness and they may be why you're hitting a speed bump. Okay, I'm gonna breathe. Hope y'all are breathing with me. It's a real good way to learn. Emails and communications. It's a great thing to add onto your email signature. I always, ensure that there's information here for respecting name, pronouns, access needs, whatever someone needs to be treated, how they like to be treated. And again, like I add my own access needs here in my email signature that I'm fragrance free. Um, yeah, the time is flying. I'm gonna keep moving. Privacy and confidentiality, we pretty much covered this, right? Thanks for telling me who else is supportive in your life. Yes, including pronouns en español to indicate that you're bilingual. That's fantastic. And I love that practice for folks that it's applicable for. Thank you for sharing that. Um, Inclusive language, really just say what you mean. If you mean people who can get pregnant, say people who can get pregnant. If you mean people who menstruate, say people who menstruate. If you mean people assigned female at birth specifically, say that, right? Um, Really just be, and if you mean men, then mean men, right? And then trans men are included in that. Anybody who identifies as a man is included when you say men, right? Just be very specific. It's really the best way to communicate, especially when it comes to inclusive language. Some language that's not really working when we say his or her. Again, sometimes sir, ma'am, and miss can be a sign of respect for folks. Again, just make sure that that's like not happening to strangers necessarily, because it can be it can be not great. Um, the gendering of period products as feminine care, feminine hygiene products. Ladies, this is a big pet peeve for me. Um, because I know a lot of cis women who don't want to be called ladies. Um, Clean, right? This is a really complicated word that often implies a lot of stigma. So be really careful with this word. It's got a lot of uses that are not working. Um, Cisgender and transgender, those words don't have ed on them. Probably about 15 years ago they did, but that's not the parlance that's being used now. Women's healthcare, real complicated to talk about something as women's healthcare. Let's be as specific as we can, because women's healthcare can mean so many things, and unless it means prostate exams too for trans women, then it's not the most useful thing. Um, Okay. Oh, intercourse. I think I just put that on here because I think it's a really odd word that usually means penis and vagina, but doesn't actually. And again, if we're being providers that are uh, specific with what we mean, then we can be specific. We want to ask open-ended questions and avoid curiosity-driven questions. Know when something is your own curiosity and that's why you're asking it, and why you're asking something for a genuine reason to, pertain to someone's care. Consider the use of a validated measure. If you're in perinatal work, a validated measure of respectful perinatal care for LGBTQIA plus people. There's a couple of these validated measures, and I've included them here, and I've included the research in your resource document. And also just asking, right? Like, is there anything we could have done differently or better for you today in your care? Um, this is just a funny little skit. I'm gonna skip it. It's just a funny little skit about over apologizing. I've definitely um nailed that in. Just gonna keep moving here. So breaking down barriers and connecting to resources as a practice recommendation means having a building or finding an updated and vetted referral guide for local affirming referrals. These are the referrals I'm referring to: mental health therapy, case management, primary care, and specialists, including psychiatry, OBGYN, urology, endocrinology, HIV care, surgery, and fertility, legal assistance for fertility preservation, housing assistance, dental and vision providers, aging and elderly care, and addiction support. Potentially, there is an LGBTQ plus AA or NA in the area. Electrolysis and laser hair removal, voice training, name and gender marker change assistance, and patient advocates and insurance navigators. And then I've got another like special list over here. If you're like going above and beyond, knowing your area is inclusive and affirming resources for things like real estate or an exercise gym or a bank or a food bank or a hair salon, goes a long way to know like where those spots are for folks. Um, Interprofessional care, interdisciplinary care. This includes folks who work real hard, like reception staff and schedulers and billers, comm staff, or culture, overall. Reception staff, just call by last name or ask what name and pronouns would you like us to use when calling you into the exam room. And then consider not requiring patients to tell you out loud at least what exam they're there for. If someone is there for a prostate exam, and them announcing that they have a prostate to the waiting room can out them or put them in a situation that they don't want to be in, right? Consider how that could be shifted. Trained staff communicate sensitively when scheduling appointments, and that includes finding times in the day in the schedule when the clinic is the emptiest for someone who might look like the only man in the waiting room of women, for example. Um, Having billers trained on handling very typical snafus, for example, when a system has a different gender marker in it than the code requires or the insurance has. If you have M on all your documents and then you get billed for a PAP, it's going to get rejected by insurance. It's going to be a whole thing. Have folks trained on how to handle that. Using inclusive language in communications, and then just shifting our org culture, considering affinity groups, and also hopefully in ways that don't increase unpaid labor for marginalized staff. I can't believe I'm where I'm at with time and just getting to these. Well, I can believe it. I included a lot, but these practice recommendations, I am gonna just put a little bit of time into this. I want to check in with Alyssa. Is it cool if I go through this like in 5-10 minutes, or do we need to close out?
10 minutes should be good. We're still running pretty good on time. So yeah, 10 minutes should be good.
Awesome. All right, I'm going to do these quickly. And a lot of these are just going to reference the medical papers that the information is in. And those are included in resources. So we go there and you'll have the resources. Taking a sexual history, again, coming directly from the research. We are looking at a shift here in some myths and facts. It's just really important to interrogate some of that internal bias when it comes to um, thinking about. Oh wait, do we have 30 minutes? We put till 8:30. Oh
Yeah,
my
on
god!
the
Amazing.
registration, set 7:30 Central, 8:30, yeah.
Okay, I'm gonna
So
slow down a little
yes.
bit. I don't know why I thought I had to end at 8, and you literally told me before I didn't have to. I'm gonna slow down a little bit. Okay. So, some myths and facts around folks in the LGBTQ plus community. Important to take some time with these myths and facts um, to understand that identity doesn't equal behavior. Breaking that apart. And then including also ideas that certain folks don't need certain services because of their identities or their bodies. When we assume, we make an ass out of you and me. Um, thinking, that breaking down some of these assumptions. Um, So, a sexual history. Ideally, this is happening while clothed. Honestly, not every clinic is able to make this happen, and I understand that. But ideally, we're doing this when we're in everybody's clothes. Everybody's wearing their clothes. Um, Introducing yourself with your pronouns, inviting the patient to do the same, and laying out a plan for the appointment to ensure that the patient is not having a surprise procedure. Including the reason for the examination, what it entails, and being really open to questions about that. Open-ended question: how do you identify your gender? What gender were you assigned at birth? um, Getting that information, how do you identify your gender? Taking an anatomical inventory. So what reproductive parts do people have, and asking that um, in a way of, what reproductive organs do you have or not have. You can also ask this in terms of asking about surgeries, but that's not going to answer everything. Are there specific anatomical terms that you would like me to use or not use as we discuss your body? Really important and research backed, right? Instead of assuming that everybody uses the same language in a community for their bodies, asking and just using that preferred language. I'll dive into this a little bit more in a second. Are you aware of any variations in sex development or intersex conditions that were present at birth or now? Right? Um, Intersex bodies are not rare. And while folks may learn about their bodies at different rates or have different levels of understanding, this can be a good question, open ended. And then just noting the absence of any reproductive organs, for example, sorry, let me back up. Noting the absence of any reproductive organs or ambiguities in gender assignment at birth, to sort of parse out any of those questions about intersex conditions. Do you have sex? I have a big pet peeve around the question, are you sexually active? That question to me asks nothing, it answers nothing. Like, we have never defined sexually active, and most people don't have a good definition for it. If they do, great, right? But like, do you have sex? We're also opening the door for folks who don't have sex, and that's great too. Um, what are the genders and anatomies of your sexual partners? So, I've been a part of a lot of trainings at medical schools where they train folks to ask, what are the genders of your sexual partners? I don't think this is a useful question, because that's not giving all that much information about risk. And that's the important question that we're asking here, right? Is like someone's medical well-being. Um, and so asking gender, but also like asking the genders and anatomies. Um, are you having sex with someone who has sperm? Great question. Can we get a lot of really useful information there? Um, how do you have sex with them, or what body parts do you use? Again, if we're doing a sexual risk assessment, this is going to be the important information. And then giving some examples, because I've seen many situations where somebody says, how do you have sex with your partner? And the patient goes, uh, like, well, right? Or, on Sundays, giving them some language to use here, around sort of what goes where. And then asking, do you use toys again? Because we're assessing risk here, and that is something we consider when we assess risk. A little bit here, from one of my favorite resources, the Gender Book, on intersex bodies. Some of these estimates are as common as 1 in 100 births, all the way up to studies that look at like 1 in 1,500 births. Um, but bodies come in a lot of sizes and shapes, and that includes, excuse me, the development of genitalia. Um, and so I just wanted to give a little context, if folks didn't have a lot of familiarity around what I meant, when I talked about questions about intersex bodies. Um, Fantastic word cloud here, around, this article is literally called From Shark Week to Mangina, an analysis of words used by people of marginalized sexual orientations, or gender identities to replace common sexual and reproductive health terms. Fantastic journal article. This is I do in sex ed workshops, we do an activity that looks similar to this, where we name all the different words that people use for their parts, just so that we are expanding our lexicon here, because words like vagina and penis are not going to feel right for a lot of people when they describe their bodies in the trans and non-binary community. So real fun word cloud, just to give y'all an idea of sort of what I'm talking about. And someone might say, they're not going to say, I don't know, they might say to their provider, right? Like, oh, I use the word mangina, right? But they might say, I prefer genitals. I prefer that you say the word genitals over vagina, right? And just giving folks a chance to say like what words and they use or don't use. They don't have to tell you everything, right? But just like, how do they want you to refer to their bits, as you interact with them as a medical provider or someone doing a sexual history. Um, just some more gender neutral language that can be used in pelvic examinations, as we're looking at things like internal organs, internal parts, chest, outer folds, outer parts, and clarifying when you need to use one of these terms, like what I would refer to on a medical chart as the vulva, right, or something along those lines. But frontal pelvic opening, internal canal, these are all medical terms, and they're pretty specific, so we can use them. Um, Continuing with our sexual history best practices, do you use barrier methods to prevent sexually transmitted infections? Do you have any questions or concerns about STIs today? Pretty typical, right? And then looking at, do you have any plans to become pregnant? Do you have any hopes or plans to have children or build a family, right? Because people build families in a lot of different ways. Has anyone ever made you had sex that you didn't want to? Has anyone ever hit you or hurt you physically? Do you feel safe at home? We're, you know, pretty standard here in training around sexual history, that we're screening for intimate partner violence, we're screening for sexual assault, we're screening for safety at work and home. Um, what else about your sexual health and practices should we discuss to keep you healthy? Love this question. Super open ended. Leaves the door open for the patient to really answer that question in a lot of different ways and share a lot of information. Um, Pausing to breathe and also take any questions that folks may have. Okay. Questions at any time, bring them on. So on sexual risk, when we assume this is me just being punny here, right? But important that we're not assuming that expression or presentation is the same thing as identity, and that that's not the same thing as like sexual activity, right? That we cannot make like an A to B to C here. That when someone looks a certain way, that they identify a certain way, or that they have a certain kind of sexual activity that they engage in. Also that we're not assuming that a kind of identity means that they engage in certain practices and behaviors, right? If somebody says, I'm a gay man, we're not assuming right off the bat what practices and behaviors that they engage in as a result. Um, that the somebody has a sexual activity or that they have a partner means that they're monogamous, right? We don't want to be assuming that everyone is monogamous or has just one partner. Um, that activity, all activity means consensual activity. When we look at the ubiquity, especially of childhood sexual assault, right? We need to be very careful that when we're talking about sexual activity, we're not assuming that it was consensual. Um, Similarly, looking at that all pregnancies are not wanted pregnancies, right? As repro providers, y'all are usually pretty great at this, but I wanted to include it. And specifically, just this assumption that not all adult people have sex. um and you know, we're just making room, we're just expanding, you know, opening doors, making room for folks um to share with us and feel safe and included and affirmed as they share things that are very difficult to share with people, especially if you don't know them that well. All right, I'm going to talk a little bit about the PAP and the pelvic real quick, and some best practices here. Again, we're getting pretty specific, but this is really exciting knowledge to be able to pass on to folks. So, for a trans patient, and that's where we're looking at the, you know, the affirming practices here. Be prepared to advocate with insurance. Um, because they're going to see an insurance code that then they assume a gender, and sometimes the systems literally will not allow them to bill a female patient for what they have coded as a male procedure or vice versa. And it can be a huge pain in the ass. Consider if this is within your scope, prescribing to, if somebody is on testosterone, gender affirming hormone therapy, prescribing up to 2 weeks of estradiol cream for vaginal atrophy, and potentially an anxiety medication. There is a higher incidence of inadequate tests when someone's on testosterone and they're taking a pap test. So indicate the testosterone on that cytology requisition. Advise the patient of of the fact that like there is a higher prevalence of inadequate tests and there might be a potential need to return for retesting. And if the results are inadequate, use the same 2 to 4 month guideline for retesting as with cisgender patients. Some people do feel that the threshold here should be lowered. And again, I'm drawing from the medical research here. I'm not a doctor, but I read medical research and I have experience as a gynecological teaching associate. Super open to defer to the expertise of folks with far more medical training than me. I just want you to know what the most up-to-date research says, and that's what this is. Okay, the trauma-informed pelvic. So allow for maximum choice. Choice is autonomy. Autonomy is, you know, the ability to decide how something happens, even if there's limited choice within that. You know, the choice to have a pelvic, of course, but then also the choice of like even the little things of that experience, whether it's the lighting or the table angle or headphones on low volume, they can still hear you, right? I cannot tell you, this is slightly related. I cannot tell you how much my experience of going to the dentist changed once I went to a dentist who allowed me to listen to a podcast during the dental work. Changed everything. And they just did a visual cue if they needed to communicate with me during. Whether or not they have a chaperone and who that is within your clinic's policies, the amount of information that is shared as they go along. Do you want me to narrate every step, or do you want me to just let you know when something's going to change in your sensation? The introduction of touch, so that the first touch on the client's body is not on sensitive tissue. The option to use a table extension versus footrests, based on patient comfort, and of course flexibility level. Allowing someone to have a blanket or fuzzy socks or a comfort item. Um, from a provider perspective, it probably seems like a very small and trivial thing to change. From a patient perspective, it can change everything if you get to have your favorite fuzzy socks and your squishmallow with you as you have a pelvic, or whatever else it brings you comfort. Allowing patients to undress only from the waist down, if that is a part of that process. I've got a question in the chat that I will get to in just a moment. Um, allowing patient actually I'll get to it now. So allowing some patients to self-insert speculum. So do I have thoughts on self-collected samples is the question. I have thoughts on everything. Of course I have thoughts. Um, this has not been something that most places have rolled out. And I have some hesitancies just around ensuring that folks are like adequately um, they have enough information to do a self-collected sample. But if they're informed and they have enough knowledge to know like here's what you're gonna do, um, then yeah, I mean I think it can be a game changer for how someone experiences a pelvic or a pap. Um, yeah, some folks in the chat that the research from the UK supports it, and it's been incorporated into practice, and that there's a whole walkthrough. Yeah, amazing, right? I think if someone is adequately walked through the process, and they have the knowledge to not only properly collect the sample, but also what was I going to say? I completely lost my train of thought. But yeah, this honestly like is not something I see folks implementing very often in clinics. But if this is something that is able to be incorporated, and it's able to be incorporated in a way where the patient feels super empowered and has all the information, then it can be, yeah, it can be a wonderful thing. um, I think that yeah, it's not as widely implemented as it probably could be or should be. And my hesitations are just that I think that, sometimes folks are like, okay, yeah, you can self-insert. And then there's like not a lot of follow up from there. But it's, if there's a whole walkthrough that goes with it, that's fantastic. Yeah. Um, so avoiding unnecessary touch. Oh, wonderful. And we have a resource in the chat for this research, which is fantastic. Thank you very much for sharing that. Um, super excited to dive into that research. Avoiding unnecessary touch. I have seen this most often when I am training folks who are used to comforting touch like nurses, but a touch on the back or the arm, which might seem, I think, for some people a little bit more feel more acceptable in a different exam. In a pelvic can be very discomforting. Not that anybody should be touched without their consent in a doctor's office, right? But just that like comforting touch may not be so comforting for a client. Patient, you have to forgive me. Client patient goes back and forth in my head as a therapist. Allowing the patient to get fully in position with the practitioner next to the table instead of at the base of it. And so that the patient doesn't feel like they're scooting directly towards the practitioner's face, but that they're fully in position, and then the practitioner gets into their position, and then maybe there's some adjustment for comfort. Um, Changing our language here, so that we're really using this medical language of table instead of bed. We're not riding horses, so we'll use footrests instead of stirrups, drape instead of sheet, and that this should be opposite. This on this slide, this the whatever this is, um, which one is better than the other. Let's use bills instead of blades. No one wants to think necessarily about speculum blades. I think speculum bills is a little bit easier language. Um, we want to specifically avoid language around do this for me, right? Like scooch down for me or scooch to the right for me. The patient's not doing it for you. They're doing it for their own health. And just a little bit odd to the dynamic. When we are telling patients to relax in a pelvic can be really triggering language. So it's good language to avoid. And then comments about body or genital changes, super unnecessary, just something to be aware of. And then discussion of the stop or pause clause, which I'm sure that folks are using. But just, if at any point you would like me to stop for any reason, let me know. I always add, and I will. So telling the patient, like, you can tell me to stop at any time or if you need to pause at any time, and then reassuring them that when they say that, I will stop, right? If you need to stop or pause at any time for any reason, let me know and I will, right? Um, to know that, when you hear it, you're going to listen. Um, Here's some of the research, the most recent research around transgender breast screening recommendations, because these are shifting as more research is happening, and transgender patients are less likely to receive the recommended cancer screenings than their cisgender counterparts. Oh, and some awesome information in the chat around lactation induction in trans women, which I love. Thank you so much. So increased risk in breast cancer in trans women compared to cisgender men, and in trans women that risk of breast cancer increases during the estrogen hormone replacement therapy and or anti-androgen. So the characteristics of the breast cancer resemble what is typically thought of as a female pattern versus what is typically thought of as a male pattern in breast cancer. Many breast imaging centers don't contain the term transgender or information pertaining to transgender breast imaging services. And so they are more likely to, folks are more likely to feel like there's not a place for them in that space. And it's important that it's explicit that there is. So the current guidelines are essentially looking at under 5 years of hormone use. Screening mammography beginning at 50 years of age, every 1 to 2 years. Transgender men without top surgery, we're looking at similar screening to cisgender women with top surgery. There's not a lot of research. There's not a lot of research, period. But consider a dialogue with patients and breast awareness. This is super binary, the way that this health communication is set up, and actually the way the research was done. And so, I want to acknowledge that this is not perfect here, but definitely good to be aware of these recommendations as the research proceeds, and as research is halted by a lack of funding, there's going to be a lot less of this research in the coming years coming out. All right. When we're looking at an affirming prostate exam or a prostate exam for transgender clients, I will acknowledge this is far less my area of expertise. I don't have a prostate, and my GTA work has not included. It's included the prostate exam a couple of times with other helping with that exam for UTAs, but it's not come up for me. So acknowledging that as with all the other communication here, I'm following the most recent research, but I've got a little less expertise here. Same deal though, be prepared to advocate. So the research suggests that trans women on gender affirming hormone therapy or following a gender affirming surgery do have lower rates of prostate cancer than their age matched cis male counterparts. But the diagnosis and treatment can be more nuanced. Lots of information here looking at the necessary of the digital rectal exam and the PSA test, and looking at family history is a big part of this, of course, but there are some studies that suggest that they're only necessary with late stage. of gender affirming hormone therapy. And what I mean by that is late started. So like later in life, if someone is starting estrogen over 50, for example. Because this is really where the sort of clusters are presenting in the research. The prostate sits in a different place for someone who's had a vaginoplasty. Without vaginal stenosis, this is going to be in the front of the vagina and can be performed that way. PSA levels are going to look different for estrogen and testosterone blockers, and so really important to be up to date with the research here on the PSA. I'm really looking for a difference in this test as opposed to those levels, a difference from a previous level. And important to note that this, may be asymptomatic, partially because the prostate's not increasing with age for someone who is on GAHT like it normally would. Or may actually get smaller. So just making folks aware of what this is going to look like for folks to engage with the most recent research, and also knowing that there is really limited research, and just that is kind of part of it. And so it's a lot of folks are sort of building these considerations recently and from their own experience in treating patients. So from the same article, this is pretty complex, but the flow chart around decision making for whether or not a digital rectal exam is going to be indicated for a transgender client. Um, and it's really wonderful that this research exists. So something to be really aware of. Um, there is a common myth that anybody starting gender affirming hormone therapy needs fertility preservation. Um, the research is there's not a lot here and it's not great, but it is at this point not fully considered necessary for initiating testosterone. Initiating estrogen fertility preservation is still recommended, but there's some information and research suggesting that not even that is uh, necessary. Whereas at the beginning of a lot of this research, everybody assumed that everybody doing gender affirming hormone therapy needed to do fertility preservation, and that's just not necessarily the case. Um, because testosterone is not an effective birth control, nor does estrogen reliably entirely halt sperm production. Important to note that folks may want to seek contraception because menstruation can be dysphoria inducing, and that in that case, contraception can be a part of gender affirming care. If someone has vaginal atrophy due to testosterone, it's going to be an important time to consider that estradiol as well as an anxiety med and potentially misoprostol. Um, and as we had a resource shared in the chat, that there's great evidence for lactation induction in trans women and trans feminine folks. So it's an important thing to know um, about the possibility of this flow chart for gender affirming contraceptive care, or the assessment of contraceptive need, is coming directly from the research, and it is going to be a good thing to think about in terms of taking this anatomical inventory, as well as what the patient is wishing for their own body and their own control of their contraceptive and reproductive capacities. Um, Fantastic research here that I wanted to share for those of you who are in primary care, or providing gender affirming care outside of the surgery and hormone pieces that we just discussed, that providers play a really important role in managing the side effects of um, gender affirming body modifiers, to ensure that people can continue to affirm their gender identities. So real quick, we're looking at things like binding, tucking, packing, and using a stand to pee. Um, Binding being the use of something to make one's chest less prominent or more flat. Tucking being the process of um, moving what on a medical chart would be the penis and testicles sort of either back up into the body or sort of taped along the groin to reduce the appearance of a bulge. Packing being using something to create the appearance of a bulge, and a stand to pee being something that someone um, with on a medical chart would be a vulva and vagina can stand to urinate. So there are side effects for using these products and engaging in this type of gender affirming body modification. And it's really important that folks have assistance in managing those side effects so they can continue to affirm their genders. And so we're looking here at what typically these side effects look like. And just the importance of providers helping folks manage these side effects. Maybe it's finding a binder that fits a little better and is not too tight that it's dangerous, with this being pretty common. Um, and helping folks manage any pain that's coming from engaging in this gender affirming body modification, whether it's rashes or a UTI, and just helping folks use these products correctly and safely, so they can continue to affirm their genders that way. And finally, talking about abortion care. So, what the research suggests here is that there is a rate for a higher rate of self managed abortion attempts. And yay, more resources around queer and trans abortion storytellers. That is what I've included here. The graphics from, they're fantastic. Um, and a lot of the reasons for this self management is coming from this perceived efficacy or efficiency and desire for privacy, all the way to structural issues with the lack of health insurance coverage, legal restrictions, denials, or mistreatment within clinical care and costs. So, very similar in what we see in the general population, but a little higher for folks' concerns that they will, for example, be the only man in a waiting room of women, with stigma coming along with that, or just not receiving affirming care. Um, all sexual minority groups, and this is looking at the entire LGBTQ plus community, is it has an increased abortion use from a couple different data sets. Um, More likely to be disproportionately impacted by the narrowing of abortion access. Um, and um, Looking at an overall medication abortion preference, this is not the largest study, but improving accessibility and quality of abortion care, um, looking at things that we've already talked about, like gender affirming intake forms, using that gender neutral language, and greater privacy. And again, that might be scheduling someone as the first appointment of the day or the last appointment of the day, so that that waiting room experience can feel a little bit less stigmatizing or scary. There was some interest in folks who had registered in starting a gender affirming care program. So um, I wanted to share a couple resources and recommendations here, knowing that this is going to be a way bigger project. Reach out to clinics that are similar in size, budget, population, and location, and consider a SWOT analysis. What are the strengths, weaknesses, opportunities, and threats? Consider a compensated community advisory board of folks who use or will be using the services, so that they can be contributing and sharing feedback about what they'd like that to look like. Informed consent is a gold standard for 18 plus, meaning that there's no requirement of letters. A model website, I shared that Planned Parenthood of Michigan has a real model website around their gender affirming care program. It's fantastic. Check it out. And that really was created with the input of a compensated community advisory board. So real great work to look at there. Is there a pharmacy that can and will fill prescriptions similarly to medication abortion or other reproductive care services if you're prescribing birth control, right? Like, is there actually a pharmacy that can and will fill prescriptions where people will have an okay at best or at worst, right? Um, Experience getting their prescription. Um, the WPATH standards of care are going to be where the training is going to come in. So this is the world, my brain, it's late in the day. What WPATH stands for is not coming to me right now. But this is the international board that comes together to create these standards of care. They are on their 8th edition. The 8th edition is out, and in many insurance companies are still adhering to the 7th edition of the standards of care. So just be aware that thank you, World Professional Association for Transgender Health. My brain like couldn't find it. Insurance companies may still be adhering to the 7th. And one of the main differences here is the number of letters, the need for letters by mental health professionals for accessing gender affirming care, surgeries, etc. So that's going to be the standards of care to get trained on with that knowledge that there's that complication between 7 and 8. So I leave you with some action steps and just a lot of gratitude for like sticking in it and being here. Yes, and WPATH has conferences. That's fantastic. Thank you for sharing that in the chat. Um, so personal development, that continuous self-reflection about biases, and that use of consistent inclusive language, with that growth mindset of like, we're not trying to just master it all, right? We don't do that. We don't want that. We have a culture of humility mindset, and continuing to that ongoing learning about experiences. Organizationally, audit your inclusivity practices. You can use this training to do so. Update your intake forms, create those comprehensive resource guides and referral networks. And I'd say also find them, right? They may already exist, and there's no need to reinvent any wheels here. Training all staff in inclusive communication, from the front desk all the way to the back lab. Um, and then advocacy and community engagement, challenging these like overwhelming amount of discriminatory policies that we're seeing right now, and attacks on bodily autonomy in marginalized communities, connecting with local community organizations that are doing this work, advocating for the comprehensive healthcare access. Personal accountability strategies, practice that pronoun usage and self-correction, learn from mistakes without defensiveness, seek feedback and use it and see it as a gift. I have put here, there's so many organizations doing such good work that need so many funds right now. And I'm sure a lot of you work for them. And I want to just add here that with the shutting down of the LGBTQ plus suicide hotline from 988, the Trevor Project is going to be a really important resource to help our folks get through, specifically young people. So, it's a great organization, along with all the wonderful organizations that you all are already connected to and donating to and working for. Just something that was on my mind as I was creating these slides. And I leave you with a ton of resources, a resource list. I'm going to go here. This is a resource list that's custom for this webinar, and it includes the references to all the studies that I cited. If the citations aren't perfect, forgive me. They're not in alphabetical order. And you know what? We're doing our best. But I have included all of those in the resource list that you will get in your email. You can access it here with the QR code, to dive into all these studies, to reference them. And then also some really great avenues for future training and some of my favorite resources that for you to dive into. So at this time, I'm going to pass it back and also take whatever questions folks have. I'm so grateful for all of you for being here this evening, or whenever you're watching this recording, if you are. And please don't hesitate to reach out. I'm really easy to find. Because I've just Tori at torysparks.com. I have a huge resource list on my website. If you just go to torysparks.com, and click on resources. It's pretty big. So please don't hesitate to check that out and utilize it. And if you are hoping to get some training for your organization, please don't hesitate to reach out. I really value and I'm really grateful for the opportunity to help people grow and learn. It's a real gift.